And now we move on to the final talk for the day, the one that brings cutting edge science to the forefront on the topic Advances in the Management of CA Endometrium based on molecular testing by Dr. Gayatri Gopan, consultant medical oncologist, GG Hospital and Sri Ramakrishna Mission Hospital. Over to you, ma'am.
Thank you so much. Respected seniors, teachers, and also chairperson. First of all, I thank the organizers for giving me an opportunity to present in this August audience. So after this interesting surgical videos, we will be moving on to the molecular advances in CA endometrium. So first of all, let me thank all the patients, my teachers, and also friends before moving on to the topic proper. So we know that endometrium is really common nowadays. This is now the fourth most common female cancers, and as well as in India, it is also very common. And we know that the median age of onset, the diagnosis is 64 years, and the lifetime risk is actually 3.1%. The most common histological type is the endometrioid type, and the overall survival rate now has become 81% with all the advances. And when the localized disease is identified and if it can be surgically removed, the rates reach up to 95%. But if it has got distant metastasis, then the rates are only 18%. So the risk factors for CA endometrium, we know the risk factors, that is unopposed estrogen exposure, hyperinsulinemia, then the different metabolic factors like obesity, hypertension, all these are the risk factors. And also there are genetic risk factors also for CA endometrium. So previously, we used to classify CA endometrium into two, that is a type 1 as well as the type 2. So type 1 had a low-grade endometrioid histology, the grade 1 tumors, the estrogen receptor dependent tumor that had the better prognosis. But the type 2 Bachmann classification deals about a varied histology, all the different high-grade histologies, which is P53 dependent and that may have an atrophic endometrium. But what is the problem with this classification? Why can't we follow this classification itself? The problem is that it lacks reproducibility. One person may report as a low grade, the other person may report as a high grade. So it doesn't yield a same prognostic group because sometimes they may recur and we don't know the cause for recurrence. So actually there has been a newer classification system, and also the previous classification system does not take into account many other important factors related to the recurrence, that is LVSI or nodes or myometrial invasion. So the TCGA, that is a Cancer Genomic Atlas, has put forth a newer classification that takes into account the different molecular subtypes. So the first one, it is the ultra mutated type. Ultra mutated means what? There are a lot of mutations. So there are more than 100 mutations in megabase, and mainly the mutations occur in this pole, that is a DNA polymerase epsilon exodomain. So there the mutations occur. So that is the ultra mutated variety, which we say as pole mutated variety. So that is one type. Then the another type that the TCGA has introduced is the hypermutated. After ultra mutated, it is hypermutated, where there is 10 to 100 mutations per megabase. So these are all mutation rich. So they may seem high grade, but these are actually having a very good prognosis because of the increased mutations. So the hypermutated ones are usually microsatellite unstable, or we call it MSI high. Then again we have another type, that is a somatic copy number high, that is actually the P53 mutant endometrial cancers, and these cancers have got a really bad prognosis. And then we have a non-specific molecular phenotype which does not have any particular mutations, but this can have abnormalities in the PI3 kinase pathway, and also the WNT signaling abnormalities can be there. So on the basis of this, endometrial cancers can be classified into 4. Now, is it very difficult to do all these things in our daily practice? No. With very simple test, we can actually classify the endometrial cancer into these 4 types. So what are the tests that we can do? We can do simple immunohistochemistry that may be available everywhere. This MMR, that is the mismatch repair proteins, or we call it this microsatellite instability also. These terms can be used interchangeably. That can be identified by performing IHC for 4 proteins: MLH1, MSH2, MSH6 and PMS2. If there is absence of expression of any one protein, that is considered MSI high. P53 mutant expression can also be understood with IHC. So there is a different criteria for understanding if P53 is mutant or not. So if time allows, we can go to that criteria also, but that also can be identified with IHC. For identifying this pole mutation, it requires next generation sequencing or Sanger sequencing. So whenever as the first step, what we have to identify is whether the endometrial cancer is pole mutant or not. If it is pole mutant, whatever be the other mutations that are present, the endometrial cancer is pole mutant. Even if there is P53, even if it is MSI high, it is pole mutant because all the other mutations are considered to be passenger mutations and not driver mutations. If pole is not there, pole is not mutant, what will we do? We will do MSI. We will do IHC testing for MSI. If MSI is high, we take it as a MSI high or MMR deficient endometrial cancer. If that is also not there, then we check for P53. If P53 is found to be mutant, so what is this P53 mutant? That means that there is a criteria. Sometimes P53 staining can occur. All P53 staining is not abnormal. If there is unequivocal nuclear staining of this P53, or if there is no staining of this cancer cells, but there is staining of the other control, then it is positivity. Or rarely, when there is unequivocal cytoplasmic expression, this can be taken as P53 mutant type of endometrial cancer. So easily we can divide the endometrial cancer into these groups based on certain simple available tests, but I agree that it is difficult to do this pole mutation, but that is available and it is not that very costly. So in this TCGA cohort, we have divided into all these and we have compared all the clinical features, and we, as I mentioned previously, that ultra mutated type, that is the pole mutant type, as well as the MSI high type, they may seem high grade because of the increased number of mutations, but they have an excellent behavior and they are associated with lower BMI. And another very important thing is that MSI high is the one that is associated with Lynch syndrome, and that may be associated with obesity also. Usually pole mutant and also the deficient MMR can be endometrioid. LVSI may be present, and the prognosis is very good for the pole mutant type. It is intermediate for the deficient MMR type, and for the P53 type, the prognosis is very poor. So this is what I mentioned previously. If it is pole mutant, whatever be the other mutations, it is pole mutant. If it is MSI high, whatever be the other, it is MSI high. And the recurrence rate is also very different. So I mentioned previously regarding the Berkman classification, it was very difficult to predict the prognosis. But now it is easy to predict the prognosis because we have insight into the molecular subtype of the cancer. So after understanding the type, we can do all these things in the biopsy specimen also. We have to stage the cancer. That staging is done to understand the recurrence and to define the surgical management and clinical examination, vaginal examination, this transvaginal ultrasound, MRI of the pelvis, very important to understand the lymph nodal involvement, cervical involvement, soft tissue involvement. MRI is important, and CT is also an extremely important to understand the sites of distant metastasis, and definitely a biopsy is also required to understand the type of the endometrial cancer that we are dealing with. Now coming on to the staging, previously the staging was very easy, FIGO staging. We had stage 1, that is there is myometrial invasion or not. There was stage 2, cervical involvement or not. Stage 3, where there is pelvic involvement, nodal involvement and all that. But now in 2023, there is an updated FIGO staging in which there are subdivisions, sub-subdivisions, all these things are there in this FIGO staging. So let us just deal with some parts of this FIGO staging. In stage 1A, we know that there is less than 50% of myometrial invasion. But in this, there is 1A1, 1A2 and 1A3. In this, let us just think about 1A3. 1A3 is actually, it is a low-grade endometrial carcinoma that is limited to uterus and the ovary. Always, we as oncologists have confusion whether we should give chemo, whether the uterus, whether the disease has involved from the uterus to the ovaries, it's separate, all these things we have confusion. So 1A3, just keep in mind, it is a disease, it is a low-grade disease confined to the uterus as well as the ovary. 2, again they have subdivided, we only had 1, 2. So there was 2A, 2B and also 2C, where substantial LVSI of the non-aggressive histological types is considered as 2B, and aggressive histological types with any myometrial involvement is taken as 2C. And one very important thing in 1C is that this is actually aggressive histologies which is limited to a polyp within the endometrium is taken as 1C. So all these things are different, and this is important for us to decide on the further adjuvant treatment also. Again, stage 3, there was vaginal involvement, parametrial involvement, nodal involvement. Again, this has been subdivided. And stage 4, we had only A and also B. Here, if there is invasion of the bladder or this intestinal mucosa, it is 4A as previous. 4B, there is abdominal peritoneal metastasis. And 4C is actually distant metastasis. So this is very important, very difficult to memorize. So we always check and then we write the stage of the disease. So just one thing what we need to remember, because always we have confusion when the endometrium and the ovary is involved, what stage it is. So in this FIGO stage, there is clearly mentioned how to differentiate between this 1A3 and also this 3A1. So that can be identified with if there is no more than 50% myometrial invasion, likely to be 1A3, absence of additional metastasis again, and if the ovarian tumor is unilateral, limited to ovary, there is no capsular rupture, again it is likely to be 1A3. And in the staging, in addition to all these complications, they have asked us to include the molecular subtype also. So if we know the molecular subtype, what do we do? If it is 1A, and we know the molecular subtype, we write as M, and what is the abnormality? So that is, it is 1A, molecular subtype is done, and P53 mutant. So that is what is recommended in the newer classification. Why this is important is because previously for stage 3 endometrium, we always, or stage 2 endometrium, we always used to give some form of adjuvant treatment. But now, with the advent of this molecular markers, if pole is mutant, I mentioned before that pole is having excellent prognosis. So if it is 2 or 3 with pole mutation, this gets degraded to low risk. So that is the importance of molecular classification. Okay. So in other stage 3 and also in stage 4 diseases, molecular classification is important, but we give adjuvant therapy. But for stage 1, molecular classification is extremely important. Now regarding the staging surgery, I am not going into detail. We have had excellent surgical videos and surgical presentations. As mentioned, laparoscopic surgery is advised only in early stage diseases. Peritoneal assessment has to be done. TAH and BSO is the standard. And then omentectomy is done in high grade histologies. What are the high grade histologies? Serous histologies, clear cell histologies, undifferentiated histologies, mesonephric like carcinomas, gastrointestinal type mucinous carcinomas, carcinosarcomas, all these are the high grade histologies, and in this high grade histologies it is always better to do an omentectomy also. Sentinel lymph node biopsy can be considered, but whenever there is bulky nodes, it is better to remove the involved nodes. Now after the surgical staging, then comes the adjuvant treatment. So a surgical staging is extremely important. That has to be perfect. Then only the medical oncologist can decide on the adjuvant treatment, and it is always very important now to consider the molecular markers also. So again this is classified into low risk, intermediate risk, high intermediate risk, and also high risk. So how do we classify all these things? Based on the stage, based on the grade, presence of LVSI. What is LVSI? It is a lymphovascular space involvement. When there is substantial LVSI, that is, it was previously 4, now it is 5. If more than 5 vessels are involved, it is substantial LVSI. And when there is substantial LVSI, it automatically comes into high intermediate risk. All the other high grade histologies which I mentioned previously comes under high risk. If there is P53 mutation and if there is myometrial invasion, then it comes under high risk. If it is low stage 1A, it is low grade, then that comes under low risk. Intermediate risk means all that comes in between, that is 1A grade 3, or it is stage 2 grade 1, low grade histologies, all this comes under intermediate risk. I know it is very difficult. Always we have to check and we have to confirm regarding all these things. Now, after we have so many trials to decide on the adjuvant treatment of CA endometrium, GOG trials are there, PORTEC trials are there. We usually follow the PORTEC trials, in which the low grade histologies, we do not offer any adjuvant treatment. So that is the importance of pole mutation. If it is even stage 2, pole mutant, no adjuvant treatment. But stage 3 pole mutant also comes under low risk, but we need further data whether adjuvant is not really required or not. If it is low intermediate risk, we usually give vaginal brachytherapy. There are certain conditions in which we can omit vaginal brachytherapy also, especially in females less than 60 years, but that is one treatment that we can do. For high intermediate risk, because of the substantial LVSI, that means what? There is lymphatic involvement, but it has not reached up to the nodes. So there it requires some form of treatment. So the treatment that is recommended as per the trials is EBRD, that is the pelvic RT, and we can sometimes add chemotherapy even to the radiation or after radiation. In the case of substantial LVSI or in the case of high-grade histologies, there is a benefit for chemotherapy also. And definitely for all high-risk cases, we give chemo-RT followed by 4 cycles of chemotherapy. So this is what is mentioned, and due to the lack of time, I am not going into this because this has already been mentioned. Low risk, intermediate risk, high intermediate risk and high risk, what is the management? Now what is the advance? So this again is an advance. What is the newer advance? That is the addition of immunotherapy. Immunotherapy can be applied for the advanced stage diseases with measurable disease. Now that is, if there is no measurable disease after surgery, you can just continue with chemotherapy. But if there is measurable disease after surgery, there is a benefit for the addition of immunotherapy to chemotherapy, especially in MSI high tumors or the deficient MMR tumors, because this has been proven to increase the survival. Which all are the immunotherapy agents? It is either pembrolizumab or dostarlimab. All these things are available and we do that routinely. Now coming to advanced disease, are there any options for advanced disease? Yes, there are so many options for advanced disease. Whenever this advanced disease comes, in addition to all the molecular markers mentioned previously, we do check for the estrogen receptor, progesterone receptor, HER2 status and definitely MSI to decide on further treatment. And definitely the recurrence, we have to see if it is a distant recurrence or a local recurrence to decide on further treatment, because if it is a local recurrence, again radiation or surgery can be used as a treatment. So surgery, whenever there is an option of cytoreduction, we can offer surgery, definitely taking into account the disease-free survival rate. If the patient has just progressed, there is a very low disease-free survival rate, then there is no point in doing surgery again because the prognosis is poor. Otherwise, definitely a radiation or a surgery can be offered. So we have different options for treating advanced cancer also, like chemotherapy, immunotherapy, especially in the case of MSI high tumors, even for MSI low tumors or proficient MMR tumors, we can give immunotherapy plus targeted therapy like lenvatinib. This can be easily tolerated, this can be given, and this has got excellent prognosis if there is a DFS. If there is no DFS, sometimes the prognosis may be bad, but it has got a good prognosis. For low-grade tumors, we have got hormonal agents. We have this, we give medroxy acetate, begestrol acetate alternating with tamoxifen, single agents, progestins can be given, aromatase inhibitors can be given, but not that useful. And now CDK inhibitors can also be added to this aromatase inhibitors. So that is the importance of checking for all these things. So this is about this immunotherapy. These are the various trials showing immunotherapy. So we, like in ovarian cancer, we check the platinum-free interval also. If it is more than 6 months, we can re-challenge with the same agent. If it is less than 6 months, we can utilize this immunotherapy options also. If it is MSI high, we can give single agent immunotherapy that has got excellent survival benefit. If proficient MMR, we can combine lenvatinib with pembrolizumab and the patient has to continue that. Pembrolizumab can be taken. If there is excellent response, it can be stopped at 2 years. This is given 3 weekly, 200 mg. Lenvatinib 20 mg daily. Again, HER2, if it is positive, we have options of giving antibodies like trastuzumab plus pertuzumab. Again, the antibody drug conjugates also. So we mentioned regarding the endocrine therapy also. Endocrine therapy is especially useful in minimally symptomatic disease, indolent low-grade tumors. So in such cases, we can give this endocrine therapy also. And we can give, sometimes this is the most commonly used treatment. We give single agent chemotherapy, like all these different chemo options. So in advanced disease, it is not that it is out of options. Always, when there is platinum-free interval is more than 6 months, can give again the same regimen. If it is less than 6 months, again we have different options. Then targeted therapy, endocrine therapy, all these things are there, and surgical option always, when feasible, when possible, it has to be considered. Then regarding the follow-up of endometrial cancer, I'm not going into that due to the lack of time. So the take-home message is that the most important is the TCGA classification of endometrial cancer into 4 types: pole mutant, MSI, P53, and the non-specific molecular type. Especially very, very important to decide on adjuvant treatment. Staging surgery has to be very good, and we can decide this adjuvant treatment on the basis of all these different markers. Thank you. Thank you so much.
Thank you, Dr. Gayatri Gopan, for taking us through the evolving landscape of molecular guided therapy in endometrial cancer.